So my question is related to sticking, or this perception in the medical profession around the diet being difficult to stick to. Who, out of everyone who put up their hands, has found patients who have found it difficult, or who have not found it difficult to stick to the diet? So the question is then, why is it such a why is there such a perception that it is difficult to stick with this diet amongst endocrinologists for one, but there be many others besides that particular profession? Where is the data? Why?
I don't know if there is any data on it, but I think there is a perception that it's difficult to stick to, and for some people it undoubtedly is difficult to stick to. One of the things we haven't talked a lot about is there's an enormous psychological component in eating behaviours, and a lot of people are sugar addicted and they're comfort eaters. And if you tell them that they've got to give up all their favourite foods, that's their go-to when their day is bad, they can't get their head around that. They just can't do it. And even for patients who do stick to it eventually, there's often a long period of time at the beginning where you have to hold their hand and coax them and coach them and convince them that if they stop eating sugar, they're not going to drop dead. And they really think that life will end without a donut. And actually, it won't. But some people can't do it. And and that's why I personally try and screen them first for their motivation to change, because some people are not motivated to change. They wouldn't change anything, no matter how you present it to them, or they can't, or their grumpy husband doesn't want them to, or whatever. They all make excuses, and you just have to wait until they get their head in the right space to make the changes themselves. That's all you can do.
Michael.
Thank you. The way I look at that is that sometimes it's a journey they need to go on, and people can get some really great results and fall off the wagon like they can with exercise and other weight loss phases. So sometimes it might be that they every time they re-encounter it, they just find it easier and they get better results and they stay on it for longer. How many people try and quit smoking and don't succeed? Do we stop telling them to quit smoking? No. Sometimes it's that, because it is that lifestyle change, behavioural change, it's not as easy to stick to it full time all the time, but you can revisit it, get back on the wagon and keep going.
Part of the reason may also be because specialised are exactly that. They're specialised and they're narrow focused. So when it comes to actually dietary advice or lifestyle advice, they flick past that across to the dietitians. And of course, they're not getting their success. Why they should see this diet that way, I don't really know. But they focus mainly on the symptom. To them, it's a sugar disease, and therefore they can do something about that, and they can prescribe a drug that makes the sugar go down. So they're doing the job the same way the cardiologist can prescribe a drug that's going to drop the LDL, and therefore I think perhaps they're being a little bit influenced by the drug industry. I don't really know.
I suspect that there's a bit of brain reflex response in that answer. I think people just get conditioned into just instinctively saying a thing and don't always question what that thing is. And this is one example of that. Look, it is difficult for some people sometimes, and the food environment has a lot to play into that. And, we know that the reason that the food industry the confectionery industry, for example, puts all of the confectionery items next to the checkout of the service stations is because it works. And that food environment, when you're standing there waiting to pay for your fuel, means that, if you're feeling a bit tired, you probably, you've got a chance of grabbing one of those things. So the food environment does feed heavily into making it difficult for some people who are susceptible to the food environment. Other people you'll recommend this to, and they just won't even see that food environment. It'll be invisible to them. But for a lot of people, it's really, they're quite vulnerable to that. So it is true that actually for some people it is difficult. It doesn't mean that, we shouldn't work on that. The smoking environment's the same thing. Now it's actually quite unacceptable to smoke indoors. There used to be clouds of plume inside every room, 30 years ago. So that was a different, it was difficult to quit in that kind of environment. So we need to create an environment in which it's more conducive to get rid of sugar, for example.
Okay, next question.
I'm Jackie Montefiore, a fellow GP, and I just want to say thanks so much to the speakers. I learned a lot with the presentations given. A quick comment initially before I get to my question to Stephen, with you commencing aspirin for your high calcium score patient. I think that was more than warranted, because really in that situation it's more of a secondary prevention as opposed to a primary prevention, and I think that's reflected by my understanding of some of the experts in this area. But question is, Susan mentioned the term polydoctors and polyspecialists, and I love that, and how do you guys navigate that conflicting advice that patients are getting from, their colleagues, but also, the other doctors or medical healthcare professionals that might be involved in their care? Do you kind of try and educate them in your letters back to those practitioners, or do you try and hold, presentations, or how do you manage that? Have you got any tips?
That's a really hard one. I try to talk to local doctors, GP specialists. I've given a few presentations. I'm indebted to the gastroenterologist in Cairns, John Obiga, if he's still in the room. I saw him here yesterday. He asked me to speak at the Gut Club. I spoke to an audience of gastroenterologists and dietitians, which was an interesting experience. They weren't all hostile. But I think that's all we can do. I don't know. This is the million-dollar question for me, is how do we get the specialists on board? I would like to move Sheila Cook from Toowoomba to Cairns if she'd like to move house. But I don't know. The cardiologists and the endocrinologists should be our best friends, and we need them, but we need them to be singing from the same hymn sheet.
I think perhaps the answer may come when Stephen Finney releases his 2-year results. Maybe then we'll have some really good, significant data that we can... we've already got it for 1-year results, and we've got lots of anecdotal evidence up here already, but when the real professionals come through with the unqualified and with the very qualified scientific proof that this works, perhaps that'll go a long way to helping with the colleagues.
Okay, next question.
Hi, I'm Hui Hui Kairos. I'm an occupational therapist, yoga and Pilates practitioner, and singer-songwriter. I have an interest working with people from cultural and linguistically diverse backgrounds, and Aboriginal communities as well. So my question is around, how do you balance the giving of choice to your clients and patients versus people who are looking for direct answers and direct, protocols from you to change their health, but having quite low health literacy levels as well. So I guess generally, if you could just share your experience working with cult backgrounds and clients from Aboriginal populations. Yeah.
Well, I'll just briefly say the first thing, the way I basically work is self-education of the patient. I send them to the YouTubes, so they don't have to even read, they can just watch a movie. And they can watch these brilliant speakers giving these excellent talks, and they can take from it what elements they want to, whether it helps for weight loss or diabetes, or for how to intermittent fast, for treatment of cancers, any particular topic. I make it a belief system for my patients. I want them to leave my room when they come back the second or third time, having watched lots of these things, come to the conclusion, I want it this way because it's healthier for me. It's a belief system. So a vegetarian eats that way because it's how they believe. And someone who wants to eat, whether it's halal or kosher, will do so because that's their belief system. Look, if there's a nice side effect that it also helps you to lose weight, treats your diabetes and reduces the chance of getting cancer and Alzheimer's and everything else, wow, what a fantastic benefit. But if you believe it's a healthier way to eat, you'll do it.
I suspect that I haven't had the fortune of working with many Aboriginal people, but I would imagine it'd be a lot easier to explain this because it's only been a couple of 100 years since they've been eating this way anyway, so you don't have to go back very far. I think if you go for many other cultures, we have to talk about the fact that grains are not ancient, they're radically new. you know. So it's a kind of a tautology to talk about ancient grains.
Isn't there a bread called ancient grains? Or wine?
Right.
We were just served some yesterday.
So, you know, it's been really exciting actually to get a few people of Asian descent off rice. That's been amazing. And they have, and, you know, they've reversed their diabetes. And, so I think, you know, I sometimes talk about the fact that we've, you know, I guess, unless people believe we came on an ark, that we, you know, have been here for hundreds of thousands of years, and that this is the way we've been eating for most of that time. That things even like rice and like wheat, and, you know, they're all actually relatively new, you know, in our diet. And it's not radical. It's obviously just eating animals and plants. So what's so crazy about that?
All right. Thanks for that. Dave, you've got a question.
Yes, actually, a little bit of a comment more than a question, but it was to Susan's point in which she was bringing up about lipids, a topic I get into now and again. I just wanted to say that actually, I don't even think you need to stop it for 3 months. I think actually even just 4 weeks. Certainly my research is showing that you can see enormous changes in your lipid profile in that period of time. And in fact, there's an ortho who gave me some advice to pass on to other doctors, which is a great way she puts it, because she finds out a lot of times surgery that's being recommended isn't actually needed a lot of times, because they find out when some of her patients are put on a statin holiday, that actually they find a lot of the symptoms that they thought were actually going to require spinal surgery needed to be taken care of. I like the language holiday, because that doesn't make it sound like you're the crazy person saying, well, I want to completely halt statins. You're saying, I would like to have a period of time where we can then help our perception with the patient is to determine if this is an issue. And when that happens, I recommend that you say, I do expect that LDL will probably go up, but then likewise, I also expect HDL and triglycerides to probably improve as well. And the only other comment I want to make is, when you're in the process of working with other medical professionals and you're part of a larger team, I do think it's worth becoming aware of the other things that I could say are part of the larger checklist of cardiometabolic factors, you know, all of the metabolic syndrome, things that also improve specifically for cardiovascular risk. So not just HDL and triglycerides, but hypertension, fasting glucose, A1C, all of these are cardiovascular risk markers. So if you want to do a comparison between that and LDL, you can always talk about it and saying low carb seems to be improving all of these things in this large list, and then there's just this one if you want to give it to them on LDL.
Any comments on that?
It's obvious.
Well, thank you. I find that very helpful, and I like the term the statin holiday, and I might be able to sell it a little bit to my colleague down the road. As such, he's an interesting character, so I know him quite well. So I will try the statin holiday route with him and see how we go.
Right. Next question.
My name's Deepa Mahananda. I'm one of the GPs from Sydney practicing low carb with patients as well. My question's for Susan and anyone else on the panel. In your talk, you mentioned intermittent fasting being used to break a weight loss plateau. Is there a particular protocol that you follow or something you've developed over time in your experience, and also others on the panel who are using this for either weight loss or other conditions?
I'm going to give a plug to my colleague in the front row here. It's Professor Schofield's protocol that we follow. We've got a copy, like Brooke, we have a little library in my practice nurse's room, and she lends out books, and one of our new editions is What the Fast. We've got to bring it to get your signature. Sorry, Grant. But yeah, that's the when we lend the patients, and when we get them fasting, we follow that super fasting protocol, and it seems to work really, really well for those who do it, and they find themselves rejuvenated and re-energised, and it definitely gets them off the plateau. So I've been really impressed. Thank you, Professor Schofield.
Thank you. So I've got these 1,000 of the original hardcovers, which frankly are good books, and so what I'd be prepared to do is give them to you if you're in practice, but you'd have to just pay for the freight, which shouldn't be that expensive. So you'll do 5 per practice or something. If you want to write to me, then
I tend to recommend something like an 8:16 start. So skipping breakfasts most people prefer to do, and then if we're not getting enough of a result there, then maybe even just pushing that window a little bit tighter if people are prepared to try that. Some days anyway, not every day. That's my kind of approach. Some people need to go to a one meal a day, and some people are more than happy to do that. Not everybody is or can, so it varies.
I give my patients 2 rules. If you're hungry, eat. And if you're not hungry, don't. That simple. And I explained that, maybe 2, 3, 4 weeks into this, something magical may happen. You actually may not feel hungry, and that's what does tend to happen. And that's why people then start playing with either time-restricted eating and or intermittent fasting. So with my fantastic lady who lost 1/3 of her body weight, it was just so easy for them because she wasn't hungry. She also introduced time-restricted eating and then later actually started doing the 23-hour fasting, basically, from time to time to help kick it along.
As I said during my presentation, look, it's not one size fits all, and some people come to you and that's what they want to get started with, intermittent fasting, and I definitely think it's a rockier road. It's a harder introduction for them and they might not feel so great initially, but I think when you transition people through, as a couple of consults in, people are starting to feel great, I start to say to them, exactly as Stephen said, if you're not hungry, try doing this, and progressing into that intermittent fasting on a couple of days a week. And it's a really easy transition when they've been doing low carb for a little while. So generally that's my approach, because otherwise, again, sometimes you have the thing where they're just, I can't do it, and it's hard to get them to try it again later down the track.
The one extra thing I would add is that it's best to shock the body, not let it get used to the same thing all the time. So if you're actually going to do missing breakfast and therefore do a 16-8 eating, don't do it every day. Do it 3 days a week, 4 days a week, and have intermittent days where you actually do eat your breakfast. So get it not used to the same thing all the time.
Next question.
So my name's Alec Petruszewski. I'm a low-carb GP in Sydney as well. Building up my practice, I find now that I get referrals from other doctors, especially internal referrals from other GPs in our practice, and I find the message they sell their patients varies from it's going to be the hardest thing you've ever done to this doctor's going to fix everything in 2 days, don't worry about it. Susan, you mentioned assessing motivation for patients. I just wanted to get the panel's views on whether there's any shortcuts or any successful ways you use to assess that, and conversely, whether you have any red flag signs for patients that are very likely to fall off in terms of motivation.
So I don't use a tool or anything like that. I talk to them and I ask them how they feel. I ask them, are they prepared to make changes? I ask them if they've ever given up smoking, and I ask them if they found it hard, but did they succeed? And that's quite a good indicator that they are prepared for change. You sometimes just get a feeling when you talk to somebody, whatever I say to them, they're not going to do this. And so I usually say to them, look, I think this diet would work really well for you, but I don't think the time is right. I think you need to come back to me when you feel that you can make changes. This is going to be hard. My wonderful practice nurse is very good at picking up those who are going to do well and not. But one of the things she says, and I think this is really true, is that losing weight is hard. Being overweight is hard. Choose your hard. And I often will say that to patients, or I give them a choice. I say, look, you've got hypertension, or you've got diabetes, or you've got this illness. I said, there's 2 ways we can treat this. We can do this the way we've always done it, and I can put you on ever-increasing doses and ever more medication, and you can keep popping pills for the rest of your days, and that's pretty easy. Or you can take responsibility for this. You can change how you eat. You can change your lifestyle. You don't need pills. And one lady said to me the other day, it would be really easy to say I'll take the pills, but I don't think that's the right answer. So yeah, I think you talk to your patients and really try and get into their head and see what they want to do and what they're prepared to do.
I think that's a great question actually that you've asked, and I think a couple of things spring to mind. There's behaviour, habit change is difficult, and habit maintenance is easy. So if their life is absolutely brimming with all sorts of other things that are happening that are requiring their attention, it's probably not the right time, like Susan said, and waiting until things settle down, because that habit change will require a bit of energy and a bit of thought. And the other point is emotional eating, and people are usually pretty good at identifying that in themselves. And if you openly ask, do you sometimes use food to calm you down if you're feeling really upset? They'll roll their eyes and say, "Do I?" So that in itself then is a starting point in which to explore alternative ways in which you can actually handle those stressful moments in life, and exploring at that moment where you choose to, go and get the donut or whatever, at that moment, even if it happened, last week when I've come to see you, you think, well, just think back to when you felt that way, when just before you actually made that movement, that decision to do that. Then, what were some of your options? What were other things perhaps that you could have done at that time? And let's plan, because that feeling is going to come back many times, and that's life, unfortunately. And let's think about some of the alternative ways that you're going to approach that moment when it happens again. So, there's ways that if it's that in itself is actually something that needs addressing. It will have an impact on change, but it needs addressing in itself.
Rod, you mentioned the word feeling, and that really resonates with me because I am also an advanced clinical resource therapist, which is a psychodynamic therapy. And there's a lot of people who suffer from emotional eating, and so there are a lot of ways that you can go about trying to help that. And so whether they can find the appropriate psychological treatment for themselves, whichever one that may be.
I also I actually don't really screen my patients, and I will work with whoever comes through the door, because we have tough patients with lots of other comorbidities, and we don't kind of screen them, we treat them. So when you establish the goal of that person, sometimes that helps a little bit with motivation, because if it's disease reversal or if it's weight loss, then if they're focusing on those things, that can be motivating for them. And I think it also comes down to making sure they've got the resources and the education, because people stay on track and are more motivated when they know what the journey is going to be. So making sure they're well prepared often helps with that motivation. I think also making people normalize to people that sometimes this can be a hard process, and that it's okay if they come back and see me and say, I did it for a week and then I've dropped off the bandwagon. Like I always say to them, don't not come back and see me because you haven't managed to stick to it, because we can change it and we can find, we can reverse some of those problems and get you going again. That's for a lot of people, that's how it goes. So you just kind of normalize that it's okay if they're not feeling great and they're really struggling. But I think the other thing I do to people with their motivation is, again, it comes down to what they want. Do they want results really quickly, and do they want to be really strict about this? Or are they just kind of, seeing how it goes, and they want to have, start slowly on the process? Because if that's their motivation, they only need to make a few little changes to get some benefit, and that might be enough for them too. So you kind of got to screen what they want, where they're at, and that helps with the process of keeping them on board, I think.
I'll just add to that. In terms of the emotional eaters and the maintaining motivation, one of the things we've found an incredibly useful tool is we have a closed Facebook group. And the practice nurse administers it, and she offers all the patients the opportunity to be signed up for it. They don't have to do it, but many of them do. And we've found that to be an absolutely fantastic forum, because the patients get peer support. They help each other. And a patient will put on it, I'm feeling like eating a crunchy bar, and another person will come on and say, you don't want to do that, go and eat cheese instead. And so it's been remarkable. We can sit back and watch, and we can monitor and moderate and join in and help them. And it means they can also message us at times when the practice isn't open, when they're having a crisis, or when they just want to know something like, should I be eating this? And they send us a photograph of something, and at least I'll send them back, do you realise how much carbohydrate's in that? No. So it's been a phenomenal resource. And I got the idea after watching a television programme, actually, on looking at different types of diets. And one of the things they said on that was that one of the ways of helping emotional eaters was peer support, and that's why I came up with the idea of doing it on a Facebook group. And that peer support has actually been hugely useful. And these are people who don't know each other, and obviously they agree to sign up for it, so there is a confidentiality thing there, but they're consenting. So assuming that they're giving consent to being on the Facebook group, they don't mind other people in the group knowing they're there. And then one woman started doing a Fitbit challenge, and all the other girls on the group who've got Fitbits all joined in, and now they see who does the most steps in a week and all sorts of things. And that's completely escalated out at nothing that we did at all. So if you're running a practice, it's something I would suggest that you do consider, is using the social media groups to help your patients with peer support.
Kia ora, Catherine Crofts. I've got my pharmacist hat on at this point. So this is probably a little bit more directed to Susan, but also though to the panel as a whole. How often, I absolutely applaud what you're all doing with the de-prescribing, and having performed medication reviews and tried to encourage so many of my GPs to de-prescribe over the years, I can appreciate how difficult it is when you're working with different prescribers, different specialists. The GPs don't want to stop or change anything the specialists have started, and they can be extremely reluctant, even in the face of the new evidence around LDL cholesterol, to stop the different medicines. So I'm putting my hand up to say that if you need pharmacist support from some of these sides, please sing out. But I'm really hoping, are your local pharmacists? I don't know how many other pharmacists there are in the room. I know there's at least one other. Are there any other pharmacists? I know there's Des. Right, so pharmacists seem to be relatively underrepresented here compared to a lot of other groups. But is it a resource that you use?
So this is where I use the term polydoctoring. This is where I run into a problem. I would get a home medicines review done on this lady if she was my patient. She's only half my patient, and she has a usual GP. And her usual GP is the one who can do her GP management plans and her home medicines reviews, etc. So it puts me in a slightly difficult position. And this is one of the issues I have with this lady. I don't want to force her to choose between her doctors. I want to support her, but I'm finding it very difficult because of the barriers that her usual GP is putting up. I would love a pharmacist to go through her medication and chuck them all out, because that's my experience. They're good at that. And we have a very, very good service of a local pharmacist who does home medicines reviews for our patients, and we'll go and see them and go through, and she sends me back an amazing report that says, stop this, stop that, stop this, which is great, and I oblige and stop them all. And maybe that might be the way to do it. I might maybe write to her GP and suggest that maybe he would get the home medicines review. He'll get paid for it, so he'll be happy.
Because I will also, just to add into that, absolutely support what Dave was saying about using the drug holidays, but not just for the... One challenge when you're coming through to as an international person to another conference, and something I will recommend for case studies in future, please don't use trade names. I had to stop and Google them all, going, because we use different medicines in New Zealand. So I'm assuming your Vytorin is ezetimibe, which nobody can ever pronounce.
Yes,
and it's got the statin in combination.
Yeah.
Right, okay. Because sometimes it's alone and sometimes it's in combination. So, but also with the febuxostat, consider also then again the drug holidays and see where you go. So if you can't get them stopped immediately, consider your drug holidays, absolutely.
For me personally, your question reveals my darker side. Because it's my personal single duty. What I'm trying to do is bankrupt all pharmacists and drug companies.
In New Zealand...
However, I want to save the Australian government an absolute fortune in the PBS along the way.
In New Zealand, pharmacists are paid per medication they dispense. It's the way that the funding model works. I disagree with that funding model. I have only ever been an employee pharmacist rather than an owner, and some of the owners I have worked for have got tetchy with me with the amount of de-prescribing that I have been able to achieve at times. But when some people say, if you manage to do what we're doing here with the low-carb community, aren't you going to put yourself out of business? And to that, I can only respond, bring it on. Thank you.
Thank you, Sean. Very quick comments. First of all, to Susan. Susan, your challenging patient question about phenofibrate. The field study didn't really show it did very much, except somewhat less revascularization, no life saved, probably a little better for the eyes and kidney. So it doesn't do a lot. I want to say to Stephen, I've got to say to all the younger doctors here, having understood the fact that lipids are not the way we normally read it, I went back and I did an audit of all my patients with type 2 diabetes just to see what they looked like. I found one case that stood out so much like yours, a 50-year-old Asian type 2 diabetic on very high dose statin and ezetimibe with total cholesterols that look pretty good, the threes, LDLs that went from 1.8 to 2.4, and for years I've been saying to him, that is amazing. But he got huge triglycerides. So I actually said to him, listen, I think this might be wrong. Can you do a coronary artery calcium score? It's 542, all of it in the right coronary artery, 90% stenosis. He was stented. So what I'm saying to all my younger doctor friends here is, it's probably a good idea to delve back into your patients with type 2 and have a good at their lipid profiles and consider what Stephen had advised, which was probably a coronary artery calcium score.
And the point we should make out is that my patient was on ezetimibe and a statin and developed that high score. That's point number one.
Yes.
And for Jeffrey Gerber, Dr. Jeffrey Gerber, Framingham, I think, was in the low risk.
Right.
So much for the muddy waters of Framingham.
Amazing. Thank you so much.
Let's move to the last question now.
I'm a credentialed diabetes educator and I've been doing it for 20 years and I've loved this whole conference. And I love you guys. What I've found really difficult in my practice, I work at a hospital which is just a nightmare with the so-called diabetic diet, but there might be is our dietitian here today? Because she's produced a low-carb diet for the hospital patients, which no one will look at yet, but we think it'd be great for the ones that choose to go on a low-carb diet. But the problem I have is I work at a hospital and privately 2 or 3 days a week with type 1s, type 2s, LADAs, is the fact I cannot find a dietitian that will actually encourage this as well. And so when we get our EPC plans, I actually try and see half my patients for free as a second follow-up, because often I'll get one visit and then the dietitian may get 3 or 4. And then what I've taught or started to teach my patient at the very beginning is totally reversed once they've seen the dietitian. And I very much start with, you actually put a diagram up on the board, which I use on all my patients, and I've been doing it for many, many years, about the whole curve of insulin resistance and how if we can reduce that insulin resistance by reducing your carbohydrates. So I start very slowly with them, and I just find it so difficult to find anyone else that's following what I'm saying or even understanding it. To a point, and I just want to make a comment of what happened at the hospital probably a couple of weeks ago, is a patient came in, she did have bypass surgery, she had type 1 diabetes, very overweight, having a lot of hypos, and a doctor, it wasn't at our hospital, came into her, no one's ever given her any education for many years, type 1 for 50 years. She was still on Protophane and Actrapid, the old insulins, no one had changed it, and the first thing a specialist doctor in diabetes, so I don't want to say too much, said, all you can do is get gastric sleeve. And she just went, oh my God, here I'm having as if you'd even say that someone having a bypass surgery. Anyway, so then she didn't want to see that patient again. So I went in and we discussed her insulins. She was so massively overweight because she was on so much insulin and just preventing her hypos. She has left that hospital. Sorry, that was 4 weeks ago. She has lost 5 kilos. We've totally halved her insulin on the new insulin, and we're gradually you should see her blood sugars now. We're just gradually reducing down all the carbs because her whole life was around feeding the insulin. And if somebody had grabbed this lady many years ago, well, maybe, had she been sent to me, and it was really scary because the cardiac surgeon said, oh, I don't know if you should be, I don't know if you should be doing this because, no one else, she didn't want to see the endo. So, but anyway, it's worked, and but I'm just finding it a battle to get sort of help or even referrals because I don't know how I go back to the GPs and say, can you just give me one more referral, or, you know? So, yeah, that's all I wanted to say. Sorry.
And I think we'd all concur.
One thing that really stands out to me this year, like just so the change from this conference last year to now, you know, we've not had one question yet about, oh, but are we allowed to tell people to do this, and this is not protocol, and this is not, remember, like last year that was just the whole focus of who's going to get in trouble, dietitians can't say anything. So the change that we've noticed in 12 months already, dramatic. There will be people in your area that are practicing this, but they're used to being underground, so you need to go looking for them. They'll start to surface now. You know, we're seeing changes already. And I think all we can do is we just have to keep doing what we're doing, getting the results. We're getting our case studies, and, you know, the tide is turning. So we just need to keep moving in the right direction. Just can I make one comment before we finish? For all the doctors in the room, we do have a email list that we're trying to grow that we can use as a networking agent and distributing information and those kind of things as well. So I'm going to try and get a piece of paper together. Maybe Doron or Rod might have a piece of paper where we can put somewhere. Maybe we'll put it at the marble table just in the foyer out there. If you could just put your name, your email address and where you practice, and we can add you to that list, because it's just going to be a resource going forward as well.
Okay, so that's the end of the session.